Really appreciate you coming. Just going to give a couple of minutes for people to sign in. So we'll just wait a moment. Okay, it's 12:03. I think we can get started since a whole bunch of you got here on time. So let's go ahead. So again, welcome to Echo Geriatrics Clinics. Next slide. And as you know, this is a forum with a free CME, distance technology, online learning. We're hoping to generate a bunch of discussion and get some expertise, be able to answer questions and really form a community of learning. So thanks for being part of that. We love interaction. So, we have with us today, Sarah Tompkinson, who is a social worker, who will also be part of our team here, willing to teach and share our collective wisdom with you on any geriatric topic, actually. And we love challenging cases, and that's why we're here. So we're hoping for some good questions and interaction. Next slide. Just a reminder that we need to keep everything confidential and safe. We need to be HIPAA compliant and not share any patient-related information. This is a safe learning environment where we will foster, mutual learning and encouragement. And also a reminder that these case consultations do not create or otherwise establish provider-patient relationships. This is purely for education. Next slide. A little bit on Zoom logistics, which I think you know well by now, but there is if you move your mouse to the bottom left-hand side of the screen, there is a Zoom chat function and mute tool. So make sure you're on mute while you're not speaking, and use the chat button to text any comments or questions that you have. But we love to hear your voice. And now we'd love you to introduce yourself. So if you click on the chat tool, please enter your name and whoever else is in the room with you, your discipline and organization, so we have a record of who's attending. Of course, don't forget to hit enter. And there's that mute button that you may mute and unmute to speak. Next slide. Okay, in order to receive CME credits, there will be a link put into the chat box towards the end of the talk that you should just click on, and that will help you get your continuing education credits. Next slide. And just introduction. So I'm Dr. Aida Wen with the Department of Geriatric Medicine, course director for this series, and Sarah Tompkinson should be on the line here with us, joining us as a licensed clinical social work. Next slide. Okay, and actually what I'd love to do is introduce Dr. Greg Gatchell. Wave to us, please. There you go. Yeah, Dr. Gatchell has nearly 20 years of experience in medicine. He completed both his Bachelor of Science in Biology and medical degree at Ohio University. He went on to complete a UCLA-affiliated family medicine residency in Northridge, California, and then he completed both a geriatric medicine fellowship and a medical education fellowship here in Hawaii at the Hawaii Residency Program. He later became certified in lifestyle medicine with the American College of Lifestyle Medicine and is currently working on becoming certified in obesity medicine. He has been clinical faculty at UCLA, UC Irvine, and now currently faculty at the Department of Geriatrics at UH. And he's practiced geriatrics for about 10 years and has recently transitioned to practicing lifestyle and obesity medicine at the Queen's Comprehensive Weight Management Program to patients all over the state via office and telehealth visits. And in his spare time, he loves getting into nature, playing guitar, and spending time with family and friends. And we're so happy to have him back and speak. And he was a wonderful fellow when he was with us. And so I really am eager to hear how his adventures have been going. So thank you so much, Greg. I'm going to hand
Thanks.
it off to you.
All right, let me see. I'm going to try to share my screen here. I got a presentation here. Are you guys able to see that?
Yes.
Okay. Let's see. There we go. All right. So good to see everybody. I see a lot of familiar faces. So I'm going to be talking about lifestyle medicine in older adults. And here's some of the objectives. Upon completion of this educational session, participants will be able to list the 6 pillars of lifestyle medicine, differentiate key areas within lifestyle medicine that change with age, assess the 6 pillars of lifestyle medicine in older patients, and identify diagnostic and treatment options for lifestyle-related illnesses in older adults. So some of the changes that providers might implement after this activity, you might want to learn a little bit more about lifestyle medicine if you don't know much about it. And another thought would be maybe even getting certified in lifestyle medicine. Hopefully this will increase your awareness of your patient's lifestyle habits, and you might even start evaluating your patients' lifestyle habits a little bit more, and in particular with your older patients, and also treat patients' illnesses at the source if they are lifestyle based, using the tenets of lifestyle medicine. So I wanted to start out with a case study, just to kind of get your mindset in lifestyle medicine. So we have a 73-year-old female, past medical history of obesity and hypertension. And her complaint is that she's having poor sleep, and nocturia is one of the big reasons why. She has to wake up every few hours to use the bathroom. She's going to be seeing her urologist soon. So medication-wise, she's taking amiloride, which is a diuretic. And so I was asking her questions about her diet, and she started taking actually the diuretic when she was in Portugal. And then she says, come to think about it, when I was in Portugal, I was eating this really good food, but it was really salty. So my legs started swelling. So I was put on a diuretic. And now her diet, she's living in Hawaii now, but she's adds salt to most all of her food. She told me when she eats her apples, she puts salt on her apples, and she drinks a lot of fluids up until bedtime. And then sleep-wise, she's watching TV right before bed. She complains of daytime sleepiness. She exercise-wise, not really any regular routine, and addiction and risky substances. She does drink sometimes a couple glasses of wine, kind of close to bedtime, sometimes a port. And then she does really enjoys her salt. So I almost considered that an addiction from the amount that she was using. Socially, she lives alone. Stress-wise, she's with COVID-19, she's been a bit more stressed out. And so I don't know if in the chat, a couple people could maybe say some ways that we could help out this patient. What would, or if we were going to do something to help her sleep, any ideas based on her lifestyle? Don't know if anyone can put in the chat. Cut down on the salt. Yeah.
I mean, is it even possible?
Yeah. So I think cutting down on the salt would be a good idea. Not watching TV from bed. Walk daily in the mornings and start to drink fluids earlier. Try different seasonings. Yeah, I like that. Some great ideas. Let's see, we'll just go on to the next slide here. Let's see if I can figure out, there we go. So here would be some potential ideas. I know people already mentioned, but maybe educating about alcohol, that it can be a diuretic, and drinking before bedtime could be one reason why she's using the bathroom more. Alcohol can also affect the REM sleep. Her diuretics may be affecting her nocturia, the high salt diet. She could even have obstructive sleep apnea. So maybe she might benefit from a sleep study with her obesity and trouble sleeping. We could talk about some goal setting, like maybe having her switch her diuretic to another antihypertensive. Looking into actually the DASH diet, which is the dietary approaches to stopping hypertension, cutting down her fluids a few hours before bed, basic sleep hygiene, like someone mentioned, cutting down the TV right before bed, having a wind down hour before bedtime, maybe journaling before bed if she's kind of anxious, some meditation to help with her stress. So lots of different ideas we could do. So just going to use that to jump into what is lifestyle medicine. So lifestyle medicine is the use of evidence-based lifestyle therapeutic approaches, such as predominantly whole food, plant-based diet, regular physical activity, adequate sleep, stress management, avoidance of risky substances use, and other drug modalities to treat, oftentimes even reverse and prevent the lifestyle-related chronic diseases that are all too prevalent. So little bit of history of lifestyle medicine. The term was coined back in 1989. The American College of Lifestyle Medicine was founded in 2004. And part of the impetus is that 80% or more of all healthcare spending in the US is tied to the treatment of conditions that are rooted in poor lifestyle choices, with similar statistics in many other countries around the world. So lifestyle medicine is actually being practiced in many countries globally, and it's really gaining popularity due to the rise of chronic disease. And lifestyle medicine education, it's starting to be added to many medical school curriculums. I find it kind of interesting, even some medical schools are having teaching kitchens. So the medical students are learning how to cook so they can teach their patients. And there are actually fellowships in lifestyle medicine. And even at our own UH, there's a lifestyle medicine interest group that Dr. Vanessa Wong she's heading that up. So it's just becoming a bigger focus now. So I like to look at the 6 pillars of lifestyle medicine. So I made this mnemonic, I call it SALADS, and it stands for stress management, addiction avoidance, love and connection, activity, diet, and sleep. So it's important to realize how these 6 pillars, they all kind of work together. So for example, if someone has a lot of stress, that can affect their sleep. If they have a lot of stress, they might not feel like exercising. If they're very stressed out, that could affect their relationships, their love and connection. People who are stressed out might use addictions for comfort, whether it's food or alcohol or tobacco. And if we're stressed out, we may eat differently as well. So that's just like one example if how these 6 pillars all play into each other. And you could say that with all the other ones as well, how they interact with each other. So basically with the lifestyle medicine approach, it's kind of like we just put on a little bit of a different hat, and it's more of a collaborative approach with the patient. So there's a greater focus on the patient playing an active role. So a lot of general medicine, it's more of like a paternalistic approach, where the patient is more a passive role and they're receiving a prescription or a procedure. But with lifestyle medicine, it's more collaborative, and providers work together with the patient to create mutually agreed upon goals. And oftentimes tracking is involved. So for example, we might track steps, hours of sleep, calories, maybe doing a food log. And the other thing that's often used is motivational interviewing. So that's a technique that helps strengthen motivation and goal commitment. And another thing with lifestyle medicine, it's really important to assess a patient's readiness for change. There's something called the trans-theoretical model for change. So if you guys have heard about that before, there's a pre-contemplative stage, contemplative, preparation, action, and maintenance. So we just kind of want to know where a patient is at, because we could recommend something, but if they're not ready for change, then it might not be effective. And sort of like geriatrics, lifestyle medicine is team-based approach. So oftentimes using a nurse, nutritionist, fitness professionals, social workers, wellness coach, psychologist, PTOT, physical medicine and rehabilitation, maybe exercise physiologist. And lifestyle medicine is integrated with traditional medicine. So it can be included in your practice, just kind of wearing a little different hat. And, a lot of people are actually practicing lifestyle medicine, whether they know it or not, because we do a lot of that, I think, just in our practices, but just being maybe a bit more aware of it. And it also can be referred out. So sometimes if someone that specializes in lifestyle medicine, and they could see a patient just focusing on the lifestyle pieces of the illness. So I'm just going to go through these 6 pillars and talk a little bit about pertaining to our geriatric patients or our older adults, how we might assess these 6 pillars in our older adults, and maybe some strategies of some treatment plans. So starting out with stress assessment. So stress can affect all 11 body systems. And a lot of times, as far as history-wise, our older adults are oftentimes may have lost a spouse or a close friend. There's a lot more losses that happen. There may be more financial stressors because they may be retired and not working. A lot of our older patients are also caregivers for their spouse or someone close to them. So there you can have that caregiver stress. So sometimes we might see our older patients having multiple systems without a clear diagnosis. And it can always be a little tricky in our older patients because they may have a lot of medical problems and they may have a lot of medications, but just also thinking about stress as one of the things that could be causing some of their symptoms. I like to ask patients on a scale 1 to 10, how their stress levels have been recently, like where they're running. And that just kind of gives me an idea of how their stress is. And there's something called a Zeret caregiver burden scale that if someone is a caregiver, we can use this. There's a 22 question, which might be a little bit long to do in the office, but they have shorter versions, even down to 6 questions, that it could be something that the patient could fill out. And then you could just kind of get an idea of their caregiver burden stress. So a few treatment plans possible would be just doing some education about stress and how it can affect us. In particular, chronic stress is really the thing we want to try to avoid. We are a little bit more equipped to deal with acute stress, but when the stress never ends, then that can cause a lot of medical ailments. And we could do some goal setting for stress relief, like maybe a goal setting to try to do some meditation, or just trying to do some stress relieving activities. Like sometimes I'll have my patients write a list of the things that relieve their stress and write it down, and then have them try to incorporate that more into their day or into their week. Of course, we could always do some consults, possibly a psychology consult, psychiatry, social worker, community services. The Alzheimer's Association I found is helpful for our caregivers. So if they're a caregiver for someone with dementia, and it doesn't have to be Alzheimer's, they can give support services. So moving on to our next pillar is avoiding risky substances. And so in particular with the lifestyle medicine, they're more focused on nicotine and alcohol and drugs, but I kind of try to look at other things as well. Like I like to kind of incorporate things like food, could even be salt in our example, caffeine. And with our older adults, always just thinking about drugs and other things that, we might kind of write off. We might think of that more, that younger patients might use drugs, but our older patients may not. But sometimes I've asked and I've been surprised. I had a patient in their 70s that was using meth, and I was kind of surprised about that. And as far as our older patients oftentimes have chronic pain. So being aware of pain addictions, and caffeine is one too. I was surprised. I had a dialysis patient, and I found out that he was drinking a Red Bull every day. And that kind of surprised me when I was getting his caffeine history. And a lot of older adults have those increased stressors like we talked about. So they sometimes addictions can be coping mechanisms, but they might not be the healthiest coping mechanisms. And just also to think about with our older adults, there's some changes in physiology. So the volume of distribution changes, there's less muscle mass typically and more fat mass. So that can affect our water soluble and our fat soluble medications. There's decreased levels of alcohol dehydrogenase. So alcohol may not be tolerated as well. As we get older, we have some decreased kidney function. We can also have some decreased liver size and blood flow, and decreased phase one metabolism. So those addictions may be even more harmful and have a bigger effect on our older patients, which some things to think about, that could lead to falls and injuries. It can affect their sleep and maybe even their cognition. So some treatment plans, education and counseling, goal setting if appropriate, like maybe set a goal to cut down on the caffeine, or to work on stopping smoking. The home visits in our older patients can be really enlightening, because there's that old adage that if someone tells you how much they're drinking, you got to multiply it by a couple of numbers, because it's what we're told is not always what's happening in reality. So a lot of the home visits can give more realization on those addictions. Also consults like treatment center, AA, psychology, psychiatrist, addiction medicine specialist. And so the next pillar to talk about is love and connection. And so I don't know if you guys remember this, Maslow's hierarchy of needs, but love and belonging or love and connection is one of those things that's very important. Just before our physiological needs like air and food and our security needs. So we all need that love and belonging. It's really important. And to assess it in our older patients, we could ask about their social circles, their family, activities, groups, or organizations that they're involved in. And something that loneliness and isolation is really detrimental to our health. And there's a lot of research on that. And I didn't really realize how bad loneliness was until I saw some of the research. And there's actually a meta-analysis of over 70 studies that found a 30% higher risk of socially isolated individuals dying in the next 7 years. So it is really hard on our health to have that loneliness and isolation, which is a lot more common in our older patients because they may have a lot of loss in their life. They may have lost their spouse and other family members. And, if they might have lost their driver's license, they might not be able to drive anymore, so they can't get out and do things. And COVID-19 isn't helping that much either, because that's really isolating a lot of our seniors as well. So as far as a few ideas, as far as treatment plans, would just be educating on the importance of love and connection and that socialization in our life. You could make some goal setting with the patient, like to call a friend once a week or once a day, or having a plan just to get more connected. Maybe getting involved with a senior center or a group. For one thing, for our dementia patients, they become very isolated, and a lot of the family members will keep the patients at home, and it can be really stressful for the family members, but it's also hard on the patients with dementia. So I found when our patients with dementia join adult daycare, and they get that socialization. It's really powerful. The patients are doing much better, and it's also really helpful for the families as well. The other thing for our patients that are isolated, living alone, senior housing or assisted living might be an idea to get that more socialization going on. And then as far as the next pillar is activity. And I always talk about how important activity and exercise is. There's over 30 benefits of exercise to the human body. And some things we might want to ask our patients is if they're doing aerobic exercise, if they're doing any resistance training or any stretching or balance training, if they're having falls, because that directly relates to their conditioning. And we also want to ask if they're having any chest pain with exercise or any cardiac issues that might affect their ability to exercise, any respiratory issues preventing exercise, or any musculoskeletal issues preventing exercise, or any other disabilities. Like if someone had a stroke, it might affect their balance and harder to do exercise activities. So as far as treatment, there's actually a saying, like if you could prescribe exercise as a pill, it'd probably be the best medication that there is. And there's actually physical activity guidelines for Americans put out by the US Department of Health and Human Services. If you go to health.gov, and it tells what the current recommendations are. And in general, the recommendations for older adults are the same as for younger adults. However, they also say that some balance training should be added. And in general, for older adults, when 150 minutes of moderate intensity aerobic activity per week can't be done, then they should just do as much as their abilities allow. And when we're prescribing exercise, we always have to worry about, just like any medication that we were prescribing, there can be side effects, there can be risks and benefits. So typically one of our adages in geriatrics is to start low and go slow. And we do that when we're prescribing medication, like a high blood pressure medication. But also if we're prescribing exercise, we want to start low and go slow too, because if someone starts too fast on an exercise program, they could get injured. Some consults that we might want to have is potentially like stress testing before prescribing exercise, maybe having PT or OT consult, an exercise physiologist evaluation, or a cardiac or pulmonary consult, or cardiac or pulmonary rehab, PMNR. So we may want to do a little bit more evaluation before that exercise is prescribed. And a couple ideas, I like there's something called an exercise peddler, which it looks kind of like an exercise bike, but it doesn't have the chair and it doesn't have the handles. So it's just the pedals. So for our older patients that may have balance issues, they can just sit on a chair, sit on the couch, and they can use that. There's also, I like to call the exercise machine with hair, because if a patient gets a dog, that can offer some companionship, and also they can get some exercise that way too. So going on to the next pillar of the 6 pillars of lifestyle medicine is diet. So as far as diet, some ways that we can assess is doing a 24-hour recall. So asking our patients what they ate and what they drank in the last 24 hours. Sometimes we can have them actually do a diet log. So write it down and bring it back to us, and we can get a better idea. One thing that just to be aware of is that our older adults, they have decreased thirst. So that thirst mechanism isn't exactly what it used to be. So they might actually be dehydrated and not drinking enough, but they're not having that thirst mechanism to tell them that they are. So by doing a log, it can kind of help us know how much fluids that they are taking in. And something with our older patients, they might have fluid restrictions too, so being aware about that. As far as diet, something to always ask about is their access to food. So our older patients may have some finance restrictions, so it's harder for them to afford things to eat or healthier choices. They might have lost their driver's license or have fears around driving, so it might be harder to get the groceries. They might have vision issues or sensory issues where it's harder to prepare the food. They may also have some dental issues, so it's harder to chew. So those would all be some things to think about that we can ask. And also looking at the BMI and the weights. Are patients losing weight? Is their BMI in the underweight range? On our physical exam, we could look at things like their dentition and looking for sarcopenia. And on blood work, we might want to assess some of the vitamin levels, maybe the D, B12, looking at protein levels, iron levels, maybe even a thyroid, just to kind of rule out other things. And then as far as our treatment plan, oh, and I was going to say one other thing real quick about assessment is the home visits can be really enlightening, because when a home visit occurs, we can really see what's in the house. And sometimes I've heard that when going through the house and going through the refrigerator in particular, oftentimes there might be like spoiled food in there that gets removed, and you can just really see what the person is eating. So as far as the treatment plan, just educating on healthy diet, doing some goal setting. So maybe our patient is not drinking enough water, so we might have a goal. I want you to drink 30 ounces of water, whatever the goal is, 64 ounces of water per day, and have them track it. For older patients, they might benefit from some supplements like Boost, Ensure, multivitamins. Of course, we ideally want to have them doing more of a whole food kind of plant-based diet, or just minimizing some of the processed foods in particular. And consult-wise, we might use our dietitians for some help, maybe a dentist if there's some dentition issues. Meals on Wheels, our social workers can really be helpful. Community support organizations and home visits, like we talked about. So the last pillar is sleep. So as far as assessment for sleep, so I like to ask about how much sleep someone's getting, and also about the quality of sleep. And adults need between 18 to 64 need 7 to 9 hours of sleep per night, but our adults 65 and over need 7 to 8 hours, so just a little bit less. And then there's sleep deprivation, and then there's insomnia, which both can be common in our patients. Sleep deprivation is when someone doesn't necessarily have trouble with their sleep, they just don't give themselves enough time to sleep. So that's always important. So some people, they just want to stay up and watch TV because they enjoy it, but they're depriving themselves of sleep. So that's not always the same as insomnia. So we can ask about our patients' sleep habits. Sometimes having them do a diary, or if they're tech savvy, there's a lot of things now that can track our sleep, like our watches and things like that. Just be mindful that a lot of the trackers nowadays are really good at tracking the hours, but not the quality of sleep. So they're really not that great at telling you like the REM sleep or the deep sleep, the different stages of sleep. We really need like a polysomnogram, an EEG, things like that to tell the levels of sleep, but they are good for telling the amount. And also for our assessments, looking at the medical conditions that might affect sleep. And if there's any medications or substances that might be affecting sleep, like that patient, the dialysis patient that I was surprised he was having some sleep problems, and then I found he was drinking a Red Bull every day, so I was a little surprised on that one. So looking at those things like caffeine intake. And then as far as treatment wise, educating on sleep habits and goal setting. And one thing in geriatrics, we tend to also look at deprescribing. So, we might look at if there's a medication that we can take, reduce, like maybe the diuretic in that case we talked about earlier, or even just changing the medication changing from a diuretic to a different blood pressure medication. Sometimes we may want to do a sleep study. We might even want to have a consult with a sleep medicine specialist or a psychologist. And actually, there's something called CBTI, which is actually the first line for insomnia, typically not medication. So CBTI is cognitive behavioral therapy for insomnia. And oftentimes psychologists can do this if they're trained in that. And one thing with the sleep medications, they're really not that, in general, not too effective for inducing sleep. They kind of knock out our frontal cortex and cause someone to kind of lose consciousness, but it's not the same as sleep. And a lot of the sleep medications can increase risks of falls and injury. Benadryl is a common one used. A lot of patients use alcohol for sleep, like maybe in our case that I presented at the start. The benzos, muscle relaxers, a lot of patients use those for sleep, but they might be doing more harm than good. So looking at the sleep hygiene, educating on sleep hygiene and habits, and looking into even having them see a sleep medicine specialist or a psychologist for CBTI. And just kind of putting everything together. So the goal of lifestyle medicine is to look carefully at the lifestyle related causes of disease and to treat these root causes when possible. Of course, it's not always possible, but when possible. And patients are active partners in their wellness instead of passive. And it's important to assess a patient's readiness for change. So kind of one of the things I think a lot of us learn about with smoking, if a patient's not ready to quit smoking, it's kind of hard to get them to quit smoking. So we want to see where they're at with their readiness for change. And we can plant those seeds. They might be not ready this time, but next time they might. We could use motivational interviewing to motivate and achieve goals. And we try to work on small but manageable goal setting in a collaborative fashion. And we can try that tracking, which is oftentimes helpful in assessing and goal setting. So just going to say a couple helpful resources. I think this book is really great. It's called the Lifestyle Medicine Handbook. And that's a good way to start. Lifestylemedicine.org. If you want to learn more about lifestyle medicine, they have resources there. Exerciseismedicine.org and the American College of Sports Medicine.org. You can learn more about exercise prescription. Health.gov is really helpful for the US government exercise recommendations. Dietaryguidelines.gov to learn about the US government dietary recommendations. The SAMHSA.gov, which is the Substance Abuse and Mental Health Services Administration. There's a lot of resources there, and sleepfoundation.org has some good sleep information there. So thanks everyone for your attention. I know I talked a lot and crammed in a lot of information, but wanted to see if there are any questions or anything else we can do to help.
Thank you so much. Let's see if we can get anybody have questions or comments you want to add into the chat. I know a lot of geriatricians kind of do this, right? Because but it's good to have a very specific approach, very, comprehensive framework to look through. So I have a question. In your practice, do you actually hire a team, an interdisciplinary team to work with you, or how do you pull your team together?
So right now we have a psychologist and we have a behavioral health specialist that works. We're primarily focused on weight loss because I work at a comprehensive weight loss clinic. So we focus especially on weight loss. So we have the mental health side of things. And we have a dietitian. So that's basically our team. And then the bariatricians. So that's the medical team. We have myself and 2 nurse practitioners. So we work on kind of coordinating things almost similar to a geriatrician in a sense. So we do use a lot of different consults. So if we have a patient, for example, that is trying to, they might be having some challenges and we want to increase more exercise, we might refer them to physical therapy or occupational therapy, or with the sleep issues, we might send for sleep study. For our patients with increased weight, overweight, and with obesity, we see a lot of sleep apnea. So we do a lot of sleep studies, and we work on sleep health. So that's basically what our team is. And then we do consults outside of our team here to broaden our team.
Great. So Jeff Galbraith says, while each patient is unique, in your experience, which lifestyle change modalities seem most effective in hierarchy?
That's a great question. I think it depends. So I like sleep. So I feel like sleep can be the cornerstone of a lot of things, because for a lot of people, for example, like with exercise, some people, they don't want to do the exercise because they feel too lazy. But for sleep, it's kind of hard to say like I'm too lazy to sleep. So sleep I think is a cornerstone, because sleep actually, in particular, working like at a weight loss clinic. So when we get enough sleep, it actually affects some of our hormones. So we eat less. So it decreases our ghrelin and it increases our leptin. So when we get enough sleep, then we eat less. And actually, when we get enough sleep, we have more motivation. So when people are sleep deprived, like if you can think of some time when you maybe got 5 hours or 4 hours of sleep, it might have been really recently. I know everyone's working hard, but we don't feel as motivated to exercise. We may be more likely to splurge on the junk foods when our willpower is down. So when we sleep, we're more likely to exercise, we're more likely to eat less, we have more willpower to make more of those decisions. So I would say sleep as one of my top. But I think, yeah, you individualize it to the person. So they might have sleep mastered, but stress might be the kind of the linchpin, as far as the thing that if we fix that, it kind of fixes everything else. Just kind of like that circle I showed at the beginning, like everything kind of works together. So if we just focus on one area, we fix that, it can help all the other areas. Like if someone's stressed out because of COVID and we lower their stress levels, then maybe they're going to not be yelling at their wife all the time, and their loving connection improves. And so, yeah, all these things work together.
Great. Dr. Yates, you have your hand up. Did you want to ask a question?
Yes, thanks. And thanks very much for the presentation. I think we all agree with the principles that you discussed and try to incorporate everything into our practice as much as you can. But if you're talking about lifestyle medicine as a distinct specialty, is a consultation with the lifestyle medicine practitioner reimbursed by insurance, especially Medicaid? Because I would think that, the most vulnerable could use this the most, but they have the least access to such specialty consultations.
Sure. So, I mean, we can focus on a lot of the times there's billable illnesses. So, for example, if it's obesity, if it's diabetes, if it's insomnia, we're treating those as a billable illness, and we can bill for time, and we can do that, and it can be reimbursed. So it's just a different way to treat, but it's still we'd still use those diagnoses codes, and it's still, I'm not the expert on reimbursements, but yeah, it would be covered.
Okay, and then just a quick follow-up question then. I'm assuming though for lifestyle medicine, that's a secondary certification. So someone would have to have a primary certification in another specialty, is that correct?
Right. So if you have a primary, for me, I'm family medicine, but whatever your primary is, even actually I have a friend that's a radiation oncologist that I got interested in lifestyle medicine, and they got certified. So you just have to have a primary, you just have to have a primary specialty, and then you can get that extra certification in lifestyle medicine.
Oh, I think Sarah Tompkison, do you want to share your comment?
Can you hear me okay?
Yeah.
Thank you, Dr. Gatchell. I was just commenting in the chat that really appreciated how you took the time to include love and connection as one of the pillars, because as we all know, one's mental health certainly is going to impact your physical health. And I think it's really important to have relationships, and when I think of connection, I think about relationships that our kapuna need to maintain.
Yeah, that's a great point. Yeah, it's that loving connection and mental health is really important. And when we lack that, it really bleeds into all those other areas of life, like those 6 pillars. It affects people maybe not taking their medications. It affects their diet. It affects a lot of different things. So yeah, it's a very important pillar. You're exactly right, Sarah.
Yeah, I was wondering, I know that you talked about the certification as a secondary specialty. Are other disciplines, can they get certified as well? I mean, can nurse practitioners apply for such things, or?
They can. And I apologize. I just I don't know a whole lot about it, but I know that other disciplines can. So like I just only know for myself because I know what I went through, but I know that other disciplines can. And I think maybe even social workers, dietitians, I know nurse practitioners, PA, I believe. So I apologize. I don't know the exact details, but it is, if you go to the American College of Lifestyle Medicine, it has all the details there. So yes.
Oh, Shelley Johnstone, you are on the line. Do you want to comment? You are currently in the process of getting certified?
Nice.
Yeah, so I'm a nurse practitioner, and I'm working through the American College of Lifestyle Medicine to get certified in December. So you can be board certified as a physician, or it's a slightly different qualification if you're a different kind of practitioner. There's one for master's prepared candidates, and then there are different categories below that. So, but it's all through the American College of Lifestyle Medicine. I believe it's like the same exam and everything, just a different qualification at the end.
Right. Yeah.
We share an office, by the way, so that's why Shelley, I did not transition to being a woman in the past 5-10 minutes. Shelley and I share an office, so that's why I just unmuted and she spoke.
Thanks. Great. Oh, Mahe, you want to speak out, or should I read it? Okay. Okay. Mahalo, Dr. Gatchell. I have a difficult time managing depression among my geriatric patients. We have a behavioral health provider, but our older adults tend to decline therapy. Tangible recommendations for socialization have also been difficult. What are some community resources for socializing safely during the pandemic? Local virtual groups? Any ideas? Also,
Yeah.
open up to the rest of the ECHO community here for ideas as well.
Yeah, I kind of be curious to see what the rest of the group has to offer, and I have a couple ideas. And thanks for that question, Mahi.
I'm gonna turn to our social workers here, see if Sarah has any ideas.
Well, when she talks about what specific behavioral challenges is Mahi,
Isolation.
Oh, isolation. Oh, I can really speak to
Yeah.
that from a professional and personal standpoint because my parents are in assisted living. So as a caregiver and as a social worker, it's been difficult. And the biggest, the most challenging part is a lot of our kupuno don't have they don't have experience or being comfortable with technology. So I know when we started doing, my dad knows FaceTime. That's about it. But if we started to do these Zoom meetings so that other children could participate, he didn't know really where to look. And he also has mild cognitive impairment. So he was getting more frazzled. He was definitely getting more anxious. And so, you know, I think virtual types of, I think the intent is good, but it doesn't, those kind of virtual connections don't always work. And so we did some drive-through things when, they were even at their facility, they were not even allowed to get out of the building. And then there was a time they were shut in their room. And now, if you can't do the drive-throughs, definitely the phone calls have worked. This is crazy. They live on Oahu, but I was sending postcards because a lot of that generation, they did writing and they like to get little cards. And so I had made postcards because it was simple enough. And I told my siblings to do the same. What other things did we do? We're still in the process of exploring, what else did we do? FaceTime? Oh, and the activities side of trying to get people engaged with activities. I know that a lot of times families would tell me, I don't understand why my mother doesn't like doing puzzles. She always liked doing the puzzles. So when I asked the daughter, well, how are you presenting or approaching her about doing the puzzle? She goes, well, I just give her the box. I said, here, Mom, here's your puzzle, and I'll be back. But there's no engagement. The daughter didn't realize she was supposed to be doing the activity with her mother. I said, well, I think it's just what you're communicating. You don't mean to, but you're just telling your mom, here, you go do this on your own, So, and that's good. Someone brings out a good point that you really have to know the person as an individual because it is personal. You have to create activities that are meaningful for that, the social history, their own personal interests. So I guess that Dr. Galbraith or someone mentioned that. Yeah, for sure.
I have kind of my own little framework that different ways to love and connect. So like you can love and connect with yourself, like just basically, because there's a difference between solitude and loneliness. Like sometimes we might be doing something that we enjoy and we don't feel lonely, but other times, we're maybe bored or we feel lonely. So there's kind of a difference between solitude and loneliness. So finding activities that we like to do, and then we can connect with others. So finding ways to connect with others. And I don't know if I have the best ideas right now I know it's been a little bit challenging with COVID, but I do know things like Facebook. They found that actually makes people more lonely when they're on Facebook. So some of the social media can make people more lonely actually. So I think it's better kind of piggyback on what Sarah was saying, having some of those phone calls or FaceTime, just having them check in with friends. Like you could write out a list of all your friends and then have a cycle of when you call Bob on Monday, you call Billy on Tuesday, or whatever you have a cycle of the people that you call. And then like the other ways to connect, I call kind of basically other than human. So we talk like with ourselves, with others, and then other than human. So that could be connecting with nature, like getting out in nature. It could be getting that exercise machine with hair, like getting a dog or a pet. So those would be some ways, just off the top of my head. But I think it's really challenging with COVID.
Great ideas. Oh, Mahe's very happy with all your responses. Thumbs up.
Thumbs up.
Yeah, any other comments, ideas, creative Okay. Oh, so Catherine Chu Loy says, thank you. Got to get back to clinic. I like the SALADS acronym. I've seen some older patients use those motivational water bottles and can get them on Amazon to help remind them to drink water as long as they're not on fluid restriction. I'll have to check these water
Yeah.
out.
I know there's some different brands that'll they'll glow when it's time to drink. So I mean, there's lots of different brands. Hydrate Spark is one of them, but there's lots of different brands that it'll like glow and it'll remind you to drink. There's also apps. There's different phone apps that, you know, depending on how techie our patients are, that can send these little fluid reminders to drink.
Yeah, interesting. And also before I just want to mention that we have an evaluation in the chat box that Michaela just sent. So if you just cut and paste that one and just type it in or click on it, then you'll get the evaluation form to get your CMEs. Great. Any last minute thoughts? This is a great discussion. And anyway, so tune in next month. We're actually going to have our own Sarah Tompkison. She's going to talk. It's actually caregiver month, right? And so that's the topic. Yeah, she's going to talk about dementia caregiver support. So hope to see you.
Actually, it's going to be building and maintaining family caregiver resilience during the COVID pandemic.
Oh, that's great. Perfect. That's what we need.
Okay. Thank you, everybody.
Yeah, thanks for tuning in, everybody. Good to see everyone.
Thanks so much, Dr. Gatchell.
Thanks. All right. Bye.
Okay, bye.